In this section, we will be talking about breathing or ventilation. That is the second component of A, B, C, D, and E algorithm. I am Dr. Talat Waseem. I'm one of the consultant surgeons here. So, what can we look for clinically to assess a patient's breathing status? It is very easy. If the patient is spontaneously breathing, then the patient can be either breathing normally, which is called eupnea, or maybe hyperventilating or hyperbreathing, that is called tachypnea, or the patient may be having a respiratory rate less than normal, which is called bradypnea, or the patient may not be breathing at all, which is apnea. So you have to see the breathing movements of the chest of the patient. Secondly, you can also have a look at deviation of the trachea, crepitus, flail chest, sucking chest wound, or absent breath sounds. For that particular purpose, you will have to examine the chest of the patient. So you will find all of the findings based on your inspection, palpation, percussion, and auscultation. And finally, you may require a chest x-ray. But in clinical judgment, the most important thing for you is to know whether the patient is breathing or not. Number one, whether the patient is breathing or not. If the patient is not breathing, the patient is candidate for elective or emergency ventilation. If the patient is not adequately breathing, that is bradypnea, then again the patient may be candidate for ventilation. If the patient is hyperventilating or is breathing more than normal rate, which is called tachypnea, then the patient will or may require elective ventilation. Why do we need elective ventilation in tachypnea? It is very simple. If the patient keeps on ventilating at a rate of, let's suppose, 40 per minute, the patient will exhaust soon. The patient will be breathing out carbon dioxide, which will lead to alkalosis. So if the patient is breathing more than 35 per minute, usually patient eventually becomes a candidate for elective ventilation. If the patient is bradypnic, it means the patient will be conserving carbon dioxide within the body. That will lead to acidosis, which will be again an indication of performing ventilation. Apnea is an absolute indication of performing right away ventilation. If the patient is spontaneously breathing and it's breathing with a normal rate, then the patient does not need any significant assisted ventilation. The second component of this clinical judgment, is inspection of the chest. As I already told you, you have to know whether the patient is having any deviation of the trachea, crepitus, if there are breath sounds are present or absent. So you have to, is there any wound associated with it? So you have to have a holistic idea about the breathing status. But the most important thing here would be knowing whether the patient is breathing at a normal rate or an abnormal rate. If the patient is breathing at a normal rate, then the assisted ventilation is not required. If the patient is not breathing adequately or is not breathing at all, then again patient will be a candidate for ventilation. And if the patient is hyper breathing or hyperventilating, then the patient is tachypnic and the patient may require elective ventilation to avoid exhaustion of the system. There are many interventions that you can do to provide adequate breathing to the patient who is in trauma. First of all, you must remember that provision of oxygen is not bad for any trauma patient. So every patient in the trauma setting preferably should have a ventilation with 100% oxygen. Now, there are other things. One is whether we want to intubate the patient or not. That will be decided upon whether the patient is hyperventilating, is hypoventilating, or is not ventilating at all. As discussed earlier, if the patient is not ventilating well, then the patient will require ventilation. If the patient is adequately ventilating, then there is no requirement of any assisted ventilation apart from oxygenation. And if the patient is hyperventilating, then eventually, but not necessarily at the same time, at this juncture, the patient is a candidate for any ventilation. There can be some associated chest problems, which we will discuss in chest trauma. One is pneumothorax, hemothorax, pneumohemothorax, cardiac tamponade, tension pneumothorax. These things can hamper the adequate ventilation of the patient. If such things are diagnosed, then they have to be encountered. For example, if there is a tension pneumothorax, the patient would immediately require needle decompression of the tension pneumothorax followed by chest intubation. If the patient has a pneumo or hemothorax or a combination of the both, then again the patient will be a candidate for chest intubation. If the patient has a sucking chest wound, then there will be a need for partially occlusive dressing, and the patient will be evaluated for hemopneumothorax, and if it is there, then the patient would require chest intubation. If the patient has the features of cardiac tamponade, then again the patient would be either requiring pericardiocentesis, or if there is a clot inside the pericardium, you won't be able to take it out through the needle, then the patient will be a candidate for emergency thoracotomy. So it is very important to understand, number one, oxygenate the patient well with oxygen, 100% oxygen. All of the patient can have 100% oxygen, number one. There is no harm in giving oxygen to a trauma patient, whether he is right or wrong. Number two, the decision of intubation will depend upon the rate of ventilation. If the patient is not ventilating or is not adequately ventilating, if the respiratory rate is less than 8, then again the patient will be a candidate for ventilation, assisted ventilation. If the patient is hyperventilating, on the other hand, the patient may not require ventilation right away. So eventually the patient will be a candidate for elective ventilation, but at this point, when you are short in time, you may skip this portion. If there is any associated chest problem, then you will have to diagnose it first and then act accordingly. You have to build your clinical judgment in this area. You should be able to clinically diagnose pneumothorax, hemothorax, or combination of both, or flail chest. If you are unable to clinically diagnose, you might not be having much time for yourself. You may not have the luxury of the time to perform X-ray chest or CT scan of the chest. So in those circumstances, your clinical judgment should be sound, and you will have to rely on clinical judgment to save the time. And as you know, the interventions and the investigations run together in trauma setting. You cannot delay the intervention if some of the investigation is not available or you cannot perform so because of certain reasons. So if the patient needs needle decompression of the tension pneumothorax, you don't necessarily need an X-ray chest. If it is a clinically tension pneumothorax, then you will have to go for it. Similarly, if the chest intubation is required on clinical grounds, you may have to go for it. So the bottom line is the investigations and interventions run together. If the investigations are not available, then you will have to rely on your clinical judgment in terms of intervention. You can assist the ventilation through ambu bag. Right away, if the patient is not breathing at all, go for ambu bag. Attach oxygen to it and ventilate the patient with ambu bag. If the prolonged ventilation is required, then you go for a ventilator. You may have the help of anesthetist or anesthesia team in this regard, and mechanical ventilation should be started as soon as possible. The other modalities of ventilation like BiPAP, etc. are also available, but in emergency setting, it would be more appropriate probably to go for intubation. So there are multiple interventions which are available, number one. And secondly, you will have to choose the right mix of the interventions and investigations at the time of presentation of the trauma patient. All of the patients would get oxygen 100% at the arrival of the arrival in the trauma room. Number one, there is no harm of the supplemental oxygenation. Number two is you will have to assess whether the patient is breathing or not. If the patient is not adequately breathing, the patient would require assisted ventilation. If the patient is hyperventilating, then you may delay this step of ventilation. Now you will assess the chest as well. If the patient has any features suggestive of pneumothorax, tension pneumothorax, hemopneumothorax, or whatsoever, or cardiac tamponade, then that has to be managed at this point. Thank you.